Hi, it's Dr. Centeno, and thanks for joining us live today. Got some interesting stuff to talk about. As usual, I'll start with a small didactic lecture on a topic. Today, we're going to be talking about how the pattern of neck pain and shoulder pain can help you diagnose or get some insight into which disc in your neck might be causing issues. Now, I have a lot of my CCI patients who have disc bulges in their neck, usually mid to lower neck. And the question is often, is that causing symptoms, or are those bulges just there? And regrettably, there's a lot of people walking around with disc bulges in their neck. And some of those are symptomatic and some of those are not. So we're going to get into that a little bit today. And then from there, we'll do the standard Q&A, kind of rapid fire Q&A that I usually do. The goal is to try, obviously, and get through as many questions as I can, whether it's on this topic or really any topic. In addition to this format, I try to do once a week. There's also a Reddit thread, RPICL or PICL on Reddit. And I also answer questions there, really not 24/7, but when I'm awake 7 days a week. So I like to give patients a lot of opportunities to ask questions because I think that's how we all learn, is we ask a question, we get it answered, we now know more than we did. So let's start with this today, how the pattern of your shoulder or neck pain can diagnose symptomatic disc bulges in your neck. So let's start with that one. And new format today, we'll see how this goes. I've got this in a smaller frame. So there's lots of different things in your neck that can cause pain. We know that discs in the neck can cause pain, that facet joints in the neck can cause pain. These all cause pain in specific spots, muscles, and then nerves. So we're really going to be going into some of the spinal nerves today that cause pain and what that looks like. So we've got the upper spinal nerves, which are the ones that I commonly deal with in CCI patients. The C2 and C3 spinal nerves, as well as C1, can cause upper cervical symptoms, headaches, dizziness, imbalance, etc., and other things. Really, today, I'd like to focus on the mid to lower cervical spine, because that's the one that usually comes into the conversation as an add-on to many of the CCI patients I see. So for example, we know we're dealing with type 2B or 2A instability for a patient, but then the issue comes up, hey, doc, well, I have a disc bulge at C4-5 or C5-6. What are we going to do about that? So this is really to start addressing some of that and to educate you as patients as to how some of the pains that you might be getting may relate to some of those disc bulges or not. So again, we're going to get into the mid to lower neck spinal nerves. So the first thing to know is that we have a spinal cord here. This is a top-down view of a vertebra. You can see the vertebral body, and this is where the disc would be up front. This is the back of the patient. This is the front of the patient. Spinal cord in the spinal canal here. And then as we go out from the spinal canal, it turns into the nerve root. And then part of the nerve root becomes the spinal nerve that goes to innervate muscles. And part of the nerve root becomes the sensory part, which goes to innervate skin and take sensation signals. Now, if you've got a disc bulge, that can put pressure on this spinal nerve. If you've got, let's say, arthritis in the facet joint back here, that can put pressure on the spinal nerve. And, many times we think of it as compressive pressure, but oftentimes it's irritation. So surgeons, in my experience, often sell surgeries by the idea that, well, this is compressed, we need to decompress it. 80% of the time, you don't need to decompress it. You need to reduce the nerve irritation. So spinal nerves can get irritated by bulging discs. We talked a little bit about that. Stenosis, which all stenosis means is something is smaller than it should be. So you can have stenosis in the spinal canal. That's where the spinal cord runs. You can have stenosis in the foramen, which is the part where the nerve exits. So the first one would be called central canal stenosis, often due to arthritis. The second one is called foraminal stenosis, often due to arthritis. But both of those can be made worse by a disc bulge because that reduces the space. You can also get spinal nerve irritation by instability, which is super common as we get older, right? As we get older, things become degenerative. They start moving around more, and we get degenerative instability. And any of the above can be made worse by systemic inflammation. And systemic inflammation here is a big deal. So, for example, there was one study that showed that if someone had low systemic inflammation in their body, and they had a disc bulge or herniation, it only took a couple weeks to get better. But if they had higher levels of systemic inflammation in their blood tests, then it took on average about 9 months to get better. So systemic inflammation is key here. It can take what should be a small problem and turn it into a massive, hard to recover from problem. So let's get into some of the nerves now. So this is the C5 pattern. And so this is going to be a C4-5 disc bulge. Usually, not always, it can vary a little bit depending on where it is. But this is a C4-5 disc bulge causing a C5 nerve root irritation. On the left there, you see the pattern where you can get numbness, tingling, and burning if it's C5. So the one that is often talked about amongst us doctors is this sort of front of shoulder numbness, tingling in this area, which can map to C5. But if you look at the pain pattern, which is off to the right, meaning that's the pain that you will get if you piss off the C5 nerve, it tends to be in the upper trap. And so, many patients report pain in their upper trap. They report tightness in their upper trap. And it's possible that that's going back to that C4-5 disc bulge and C5 nerve. So now as we go to C6, we're now talking about a C5-6 disc bulge. Super common level to have a disc bulge. And now we're getting numbness and tingling in the thumb here. So we've got numbness and tingling in the thumb. And we've got a pain pattern that now is kind of lowered down, kind of in that upper scapula area, kind of where the levator scapula muscle goes, the back part of the supraspinatus muscle goes. If you look at the numbness, tingling, burning pattern, again, it's going to kind of start in the neck, go all the way down into that thumb. Doesn't have to do that, but that's more common. And then off to the right, again, you've got that pain pattern, which is kind of levator scap area, upper scapula. Now we get into the C7 nerves, and this is going to be a C6-7 disc bulge. A C6-7 disc bulge is going to cause numbness and tingling and burning kind of in the middle finger. So it's similar to the C6, but rather than ending up in the thumb, it's going to end up in that middle finger area. And the pain pattern is now quite a bit different, right? The pain pattern here, we're looking at still kind of scapula, almost looks like it's upper thoracic. And I got to tell you, having had a 6-7 disc bulge, I was 100% convinced based on this pain pattern that I had some sort of shoulder problem. I knew my neck was a little messed up, but this is where I was getting my pain, what you see here for the pain pattern at C7. It was kind of right in that upper back. It was anterior shoulder. So I was convinced I had a shoulder issue until we treated the shoulder and nothing happened. And then we treated the C7 nerve with a platelet growth factor epidural, and it all went away. So you don't have to have a lot of neck symptoms with these, which is the whole reason I'm showing you these pain patterns. And now we've got a C8 nerve. Now notice, now we're talking about going from the neck to the little finger. Doesn't have to travel from the neck to the little finger, could just be the little finger. And you can see the pain pattern there for C8 now looks kind of lower down in the rhomboid area. So interesting one again, this whole lower neck tends to refer symptoms into that upper back. So the first thing I think of when I hear someone with upper back pain is, can we rule out their lower neck? And if we can, then it certainly could be an upper back problem that's native to the upper back. But it's important to realize how all this stuff works. So again, the pain pattern is kind of in that rhomboid area. Now we go to the T1 nerves, or a T1, T2 disc bulge. And notice here that we now have this stripe for the numbness, tingling, and burning that goes across the high upper back. And for the pain pattern, it's actually lower down, the lower part of the scapula, and even into the anterior chest wall. So as we go down through the thoracic discs and the thoracic nerves, it's going to kind of bounce around with that stripe, and the stripe's going to go lower and lower. And then the pain patterns will be similar. They will sort of generally be below where you would think they would be, meaning below where the nerve comes out. So how do you diagnose if these discs are symptomatic? Well, part of it is what I showed you, right? Part of it is trying to match these patterns. You also need to look at the MRI. And what I mean by look at the MRI is your doctor can't just read the report. If you have a doctor who you're seeing for this, who's just reading the report and not looking at the images with you, you're not seeing an expert in this area. If a doctor who does this work all day, every day, cannot read the native MRI images better than the reading radiologist for these types of issues, now the reading radiologist may be able to find other things, right? Other things like, is there a tumor in here, or are the lymph nodes abnormal? But when it comes to these issues, your doctor specialist should be looking at these native MRI images with you rather than reading the report. So that's the first thing you must expect if you're seeing someone who's an expert in this area. The second thing is that the doctor listens to you, meaning that there's a thorough patient history. History is critical, right? There was an old 1700s physician, Sir William Osler, that said something like, and I'm paraphrasing here, listen to the patient and they will tell you what's wrong with them, meaning they'll give you the diagnosis. If you listen to them a little longer, they'll tell you how to treat it. So again, listening to the patient, taking a thorough history is important. And then finally, a hands-on exam that lasts for more than 1 or 2 minutes, meaning a 1 or 2 minute exam is not an exam. You can't do a 1 or 2 minute exam in here. You got to spend 5 minutes palpating just the neck. And you don't palpate the neck with someone sitting. You palpate the neck with someone lying face up, with all of their muscles relaxed, and you palpate level by level, 0, 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, 7, 1. And then you do more exam beyond that. So if someone's not palpating your neck, level by level by level, asking you what hurts, what doesn't hurt, actually feeling if these joints are swollen, etc., then again, you're not getting what an expert should do in this area. And then finally, you can do diagnostic blocks. What's a diagnostic block? A diagnostic block means that you can numb up a structure, a specific structure that you suspect. So let's say we suspect the C7 nerve. We can numb out the C7 nerve and be absolutely sure that your symptoms are coming from the C7 nerve because all of that pain that I just showed you will go away. not only for the duration of the anesthetic usually, but it does give us additional confirmatory information about what's happening if we have questions. So how do you treat disc bulges like this? Well, the Regen Med approach is what we call the functional spinal unit approach. We're the ones to name that because we were the first ones to do a procedure like this. So if you see that name out there, it was kind of borrowed from us. Flattery or duplication or copying is the greatest form of flattery, I guess. But it's a platelet-based approach involving precise image-guided injections of the spinal nerves, the facets, the ligaments, the atrophied muscles, and possibly the disc. Now, injecting the disc adds additional risk. So that discussion always needs to be had with the patient, whether we should be injecting the disc or not. The other ones are much lower risk. And I often get this question: don't you need surgery on a bulging disc, right? Everyone needs surgery on a bulging disc. And the answer is generally no. About 70 to 80% of the time, you don't need surgery on a bulging disc. These issues are usually caused by degenerative instability. So you need to tighten the ligaments through injection in that case. The nerve in the joints can get beat up, the spinal nerve and the facet joints. So we can inject substances that can improve the health of those structures. And then fusing this level, the downside with a surgical fusion is that there's a 1 in 8 serious complication rate. And same thing with an artificial disc. And both of those will cause adjacent segment disease, or the neighboring areas are going to wear out more quickly. Same thing for a fusion or an artificial disc. So in summary, pain patterns can help diagnose symptomatic discs. However, you need to put all of the pieces of the puzzle together to determine what best to treat. And surgery is usually not needed in these situations. So let's go to some questions here. Nolan, I was victim to so many medical professionals only know bulges causes symptoms and know nothing of ligament or soft tissue issues. Also know absolutely zero about regenerative medicine. Yeah, Nolan, that is pretty accurate. I think we are in a situation where usually what happens, and that's the reason why I said what I said the way I said it, but usually what occurs is that the doctor just goes ahead and looks at the report, does a very quick superficial exam, maybe listens to 60, 90 seconds of what the patient says, and then makes a spot decision about what's going on. If you're going to make a quick spot decision like that, it's really hard to get it right. That's just the nature of the beast. JS, does this bulge mean a disc that's pushing into the spinal fluid? I don't know what the spinal fluid is. Maybe that's cerebral spinal fluid. So usually disc bulges don't get their symptoms from changing CSF flow. Usually disc bulges get their symptoms from irritating spinal nerves. I can't say that first name. Can bulging disc be the cause of CCI type symptoms? Can the disc touch nerves without being shown on MRI? The only bulging discs that can cause that are usually a C23 or C34 bulging disc, and that's more rare. Usually CCI-like symptoms are caused by things like the upper cervical facet joints, for example. And then can disc touch nerves without being shown in an MRI? They can, but that's going to be dynamically, right? That would mean that there would have to be some instability that would bring them in contact with one another. So things need to be moving around too much, and an MRI obviously doesn't have any movement, so you're not going to see instability on the average live face up in a tube MRI. What size of protrusion is treatable via regen? Example, 4 millimeters, and once it becomes herniation, not treatable via regen. Herniations are very treatable via regen because the body tends to like to get rid of them. As far as what size is treatable, I don't know that there's a size maximum as much as there is trying to put all the pieces together. Again, you need to realize that an MRI is not the Oracle of Delphi, meaning that an MRI is helpful, but not the end-all be-all for anything. So if, for example, we saw a 6 millimeter disc bulge at C5-6 in someone that had a large spinal canal, and they didn't have any symptoms related to that level, they didn't have anything going on exam related to that level, then that 6 millimeter disc bulge doesn't mean a lot. It's just part of the normal wear and tear and aging, and it should be ignored. Maybe you know it's there, maybe you follow it long term, but you don't really need to get in there and treat it because it's not causing any symptoms. And there are lots of people walking around right now with disc bulges in their neck and zero symptoms. Julie, I have a small disc bulge noted on MRI at 5-6. No bulges lower down. Only tingling I have noticed past several months is fine tingling in the right lower scapular region. No pain, because it's actually be caused by my CEI and upper nerve roots or even muscle causes versus disc bulges. Yeah, Julie, so in that clinical situation, I would say that for the average person, that 5-6 disc bulge is probably not causing a lot of symptoms. Then you'd have to look for other causes of those symptoms. Those symptoms could be caused by CCI. They could be caused by other issues in the thoracic spine. Carol, submitted advanced by Harry Winston. Are there any supplements that we should be taking to help with all of these symptoms while we work on our plans to get to Colorado? You know, I think anti-inflammatory supplements are very helpful here. Things like turmeric or curcumin with bioperine, black pepper extract, bioperine. So that's a good thing to consider. Other things to consider might be high-dose fish oil. That's a good anti-inflammatory supplement. Snowmask and vertebral compression at upper cervical cause pain or soreness down thoracic, legs to foot on the same side. I don't know what vertebral compression means. If what you mean is can upper cervical instability cause upper and lower extremity numbness, tingling symptoms? We have seen that happen, yes. Dennis, what causes torticollis? Dennis, right now, the leading theory about the most common cause of torticollis would be a problem at C1, C2. So if you've got torticollis, it's usually treated with Botox directly in the sternocleidomastoids. But if you look at the research as to what's probably causing it, it all seems to point towards C1, C2. Sven, I have type 2B and 3A CCI. Just had my first PICL 3 weeks ago. One of my top 6-7 symptoms is chest pain and lower shoulder blade pain on the same side. Heart problems have been ruled out. Can this be from type 2B instability? I don't think I have a disc bulge. Thanks for your dedication to CCI. Yeah, thank you, Sven. Yeah, the bottom line is that it can be due to CCI, or it could be due to a separate lower neck or thoracic spine issue. So as you heal from the PICL procedure, if that set of symptoms starts to get better, then I think we can assume it's coming from your neck. Or you can also test it by using a cervical collar, for example, and trying to see if that makes those symptoms in the chest and in the thoracic spine better, because that'll at least localize it to the neck. If none of that happens, then you're probably dealing with an independent thoracic spine issue. And it's usually helpful in patients like that to get a thoracic spine MRI just to make sure we're not dealing with something right there. Snowmask, do regen treatment make the disc bulge disappear? What can help with disc height loss? Yeah, Snowmask, you don't need to make the disc bulge disappear, because remember, there's lots of people walking around on the street right now who are middle-aged and older who have all sorts of disc bulges and will never have a day of neck pain. So disc bulges by themselves aren't a problem. They're just like wrinkles on your face, right? They happen as we get older. So they don't need to disappear at all. And then as far as disc height loss, not much is going to help with disc height loss. That means that the cells inside the disc are dead, and they're not generating the chemicals, glycosaminoglycans, to hold on to water to keep the disc nice and plump with a large height. John, is craniosacral therapy safe for CCI, Chiari, CTE patient 3 months after a PICL? John, we don't restrict craniosacral therapy for CCI and Chiari patients after the fact, so or after a PICL. Thank you for your response. Is regenerative medicine a good treatment with suspected systemic inflammation? Yeah, I would probably need to know more there. What kind of systemic suspected inflammation are we talking about? Has this been diagnosed? If so, what diagnosis does it map to? And that would help me answer that kind of question better. Snowmass, can CCI or upper cervical weakness, whether ligament or muscles, affect lower disc bulge issues? I think it can. Yes, I think having problems with craniocervical instability and over time can put more pressure on the lower cervical spine and upper thoracic spine, all things being equal. And so if you've got a problem there, it could aggravate it, and vice versa. You can also see issues lower down irritate the upper neck. Realize the spine is one thing, right? We like to call it by these names like cervical, meaning neck, and thoracic, meaning upper back, and lumbar, meaning low back. But it's one connected machine. And yes, one part in the machine might not have great impact on a distant part, but every part impacts every other part to a certain degree. JS, oh my God, this sounds like my problem. I have arthritis at C4 through 7 with frequent back shoulder pain and finger tingling numbness. Are using PRP to treat. My neuro doesn't talk platelet treatment. Yes, that we use platelet-based treatments to treat issues like that. I'm a great example. I have cervical issues that have been treated that way with platelet-based treatments. And again, neurologists are not usually the right person for these types of issues. They're just not set up to understand things from a structural standpoint in the neck or spine. And they're also not set up usually to do any treatment in the neck or the spine. They are set up to give you some medications, but that is not really what most patients need. So a neurologist is probably the wrong specialist to see for something like this. Carol, submitted advanced by Sherry Scott. I have found that sleeping with a small rolled up pillow under my neck allows me to get some sleep. Is there a problem with that? Nope, shouldn't be at all. Josh, great talk. Chris, this is Dr. Josh Soul. Many have not taught well in the disc pain referral patterns in medical training, and recognizing these areas of eugenics position has changed my practice 100-fold. I agreed if a doc isn't spending 45 to 60 minutes with you and going over images and doing an exam of your neck, shoulders, and entirety of your muscular nervous system, they're doing a disservice. Find a different physician. Yeah, so Josh is a physician I've known for a long time. In fact, I practiced for many years here with his dad, who was a chiropractor in the Metro Denver area. Josh then went to medical school, PM&R residency, and now is a newly minted Regenix physician. And he's just bringing up exactly what I was saying, which is at the end of the day, this stuff takes time, right? So if you set your practice up where you have an expectation of seeing 20 patients in the morning, and those 20 patients might be, let's say, 5 new patients and 15 follow-ups, which is very common in surgical practices, very common in family practices, very common in interventional spine practices, very common in lots of different kinds of practices. You can't do a good job. Just can't be done. That's why when we see a new patient, If we have never seen them before, it's at least 40 to 60 minutes. If we have seen them before, it might be a little bit less. And that means how many patients can you see in a morning? 6, 7 max. But that's not the case usually. So I think what patients don't realize is we're getting ripped off by the medical care system because the doctor is forced to see 20 patients in the morning. And you can't see 20 patients in the morning and do a good job. You just can't. You're going to miss all sorts of stuff. So if you're seeing a doctor, they should be seeing 5 to 7 patients max in the morning. And then you can focus and do a good job. So I think Josh brings that up very eloquently. Snowmass, sorry, I get pain down to my thoracic, leg, and feet whenever neck pain and TOS on the same side gets more painful. Is there a relationship? Yeah, I mean, there could be. It could be related to CCI. It could be related to issues in the thoracic spine. Could be related to issues in the lumbar spine, where one part of the spine is activating another part of the spine. So just realize that lots of different things could do that. JS is systemic inflammation, a marker of SED rate or CRP, which one determines systemic inflammation. So SED rate or CRP are kind of very old markers of systemic inflammation, usually elevated in infection. But there's more sophisticated markers of inflammation these days, things like TNF alpha, things like high sensitivity CRP, etc. So those are very simple markers that are usually not elevated in the average person with higher levels of systemic inflammation. Amanda, my biggest problem is dizziness and imbalance that seems to get worse with walking and turning my head. I know these things can be identical or incidental MRI findings, but could a ponticulus, posterius, but a retroflex dens be a source of the problem? How would you correlate whether those imaging findings would cause these symptoms? Yeah, so Amanda, no, usually not. So basically what Amanda's talking about is that there can be a little bony arch over the vertebral artery. That's usually not causing symptoms. And a retroflex dens in most people is meaningless, i.e. doesn't cause symptoms. Now, a retroflex dens with instability can cause symptoms, or at least increase the likelihood of symptoms. So regrettably, Amanda, it's usually a little bit more complex than that. And that's why you've got to see a super specialist who can diagnose you with upper cervical instability and start pulling through these threads to see what's going on. That's not your local neurologist. That's not your local orthopedic or spine surgeon, regrettably. So you're going to have to see someone who can look at all of that in context. Obviously, we do that all day, every day. But the answer to your question is usually not. Snowmass, thank you for explaining the details for better understanding. Happy to help. Samira, what type of CCI does one have when the C1, C2 joint shows horizontal displacement, facet gapping, or translation of 8 millimeters during rotation? Samira, we don't look at horizontal displacement in rotation as an accurate way to diagnose craniocervical instability. Now, there is an accurate way to diagnose craniocervical instability, and that would be an open mouth lateral bending view, where we're looking at C1 goes sideways on C2. That would be called facet or C1, C2 overhang. That would be done during a digital motion x-ray, or can even be done during a routine x-ray. I've got a video on how that gets done. But we usually don't do that that way because it's not what you're describing isn't an accurate way to look for instability. Meaning, in order to look for instability or any finding, we've got to be sure that what we're looking at isn't found in people walking around out there. And so we have to have studies that say, okay, well, this is the amount of facet movement we would normally see in everyone walking around. We just took 100 people off the street and we looked at that. None of them obviously had any problems. And then we looked at people with this problem and we looked at that facet movement. And regrettably for that measurement, that has not been done. So that is anyone's guess as to what's normal and abnormal there. Hamad, can you talk about IIH and upper cervical instability? Is there a correlation? There can be a correlation. So what Hamad is talking about is increased intracranial hypertension, meaning the concept there would be that the outflow of cerebrospinal fluid or venous blood from the brain and head would be stopped up or decreased, and that would cause increased pressure up here. So you can see things like that when you have blockages of cerebrospinal fluid flow, things like a Chiari malformation or a dens that's actually touching or pushing into the medulla, cervical medullary syndrome. You can see things like that when you get intermittent blockage of the internal jugular vein. Now, having said that, I think this is way, way, way overdiagnosed. This seems to be the default position anytime someone has a headache or increased pressure in their head. And regrettably, there's usually a much easier explanation for why someone has upper cervical issues than headache. It's usually coming from the facet joints or it's coming from swelling in the bursas, rather than increased intracranial hypertension. So just be careful with this because this one is way, way overdiagnosed in my opinion without any actual data, right? In order to get data on that, we can't use an opening pressure down in the lumbar spine for something like a spinal tap. We need to be able to float a catheter from there into the brain and measure the pressure there. And then if we have really high pressure and it's associated with other things like papilledema of the optic nerve and other types of findings, let's say on MRI, then we can say, yeah, within a reasonable degree of probability, as long as we've ruled out the upper neck. So for instance, we've injected all the upper cervical facet joints and this headache didn't go away. We injected all the occipital nerves and this headache didn't go away. Now we think this is really being caused by increased intracranial hypertension. But that type of workup is almost never done in patients who are given this diagnosis. So be very, very careful there. Edgar, hi, Dr. C. I have CCI type 2B on one side, 3.8, including C, 4 through 6 annular tears with a 2 millimeters. Don't know what a C7 disc bulge is. Maybe you mean like a 6-7 disc bulge. I have upper back and shoulder pain and biomechanical issues. Would you treat the disc here? Edgar, that's a decision that has to be made based on a review of everything I talked about, right? That has to be made based on a review of your imaging. It has to be made on a review of your history. That includes everything from your symptoms to your response to treatment, and then ultimately a hands-on physical exam. And then you could synthesize an opinion as to whether or not your issues are being caused by the craniocervical instability, type 2B that you describe, or the annular tears, or the very small 6-7 disc bulge, or something else entirely. So regrettably, that's just not how good medicine works, right? We can't throw out a sentence or two and get a diagnosis because the likelihood that we're going to be wrong is very high. Submitted Advanced by Harry Winston. I found that fish oil helps quite a bit. Does eating fish have the same benefits? Yeah, it's a good question, Harry. I've never eaten enough fish to know, so I don't really have any great personal experience with that one. The fish oil stuff comes from populations that do eat a lot of primary fish-based diets, and they seem to have less systemic inflammation. So that's kind of where that started. Or Eskimo populations where they use fish oil, kind of like we use butter or salt. They put it on everything. So I'm not quite sure if eating a lot of fish works, because if you really look at where this started, it started in some of the Inuit populations, meaning the concept, and they don't just eat fish. They then manufacture fish oil and then use fish oil as a condiment, basically. So it probably isn't enough just to eat a lot of fish. You probably have to use the fish oil like those guys do, which is for Western taste, probably pretty hard to do. Zach, any considerations for rapamycin or GLP-1 agonists for PRP, BMC, stem cell treatments? Well, rapamycin is a toxic drug. I know there's been some information on that this could help with anti-aging based on mouse studies. But even if you look at the crazy dude online who's trying to live to 100 or more, I think his name is Brian Anderson. Maybe I got that wrong. I think his first name was Brian. He had to get off of rapamycin because basically he was seeing increased signs of aging once he was on it. So the mouse data wasn't translating to a human in that case. As far as GLP-1s, listen, GLP-1s are, those are, just so everyone knows, those are drugs like semaglutide, tirzepatide, that's Ozempic, Mounjaro, etc. And the good news about those is those probably do reduce systemic inflammation to a certain degree, in that they can help solve metabolic syndrome, which is a big driver of that kind of systemic inflammation. So at the end of the day, anything you can do to lose weight and get your weight back to high school levels is good. And so if a GLP-1 can get you there, I would highly recommend it. As to whether or not it's going to help PRP or BMC or stem cell treatments, I don't know. But I can say it sure ain't going to hurt, and it'll help lots of other things. JS, I experienced dizziness when I turn my head to the left. Is that a symptom of bulging disc? Generally not. So a bulging disc would be the least likely of things to cause that problem. Again, you would need to be seen by a super specialist to try to figure out why that's happening. The first thing would be ruling out issues in your inner ear. You can kind of do some of that by doing your own testing. So if you sit in a chair like this and you have someone hold your head still and you turn the chair, obviously you're putting turning pressure on the neck, but you're not doing anything to activate the inner ear. And so if you're still getting the symptoms like that, then it's probably coming from your neck rather than your inner ear. And then you got to figure out where it's coming from. Usually the upper cervical spine and upper cervical facets would be a pretty good bet if you had to lay bets on that one. Engine repair gal. Will the new study include DMX before and after? So will those be picked at random? Yeah, it's a good question. We put that out there to our larger group. I think before I left on sabbatical. So I don't know how many of those we've gotten back or how many of those patients we saw during that time period took us up on that. That's the biggest problem with before and after DMXs. I just had someone send me a before and after DMX. She's doing great. It showed decreased movement, but regrettably, that's kind of hand-picked biased data. And you really need a case series where everyone or almost everyone gets a before and after. So we tried to do that before I left, but I don't know the status of how many of those people we actually got to do it. I think we're even giving like a $500 credit or something. Zach, how do I find out about live streams before they happen? Zach, there are two ways to do that. One on Facebook on the Centeno-Schultz channel. Another one is on the Reddit thread. So if you go to Reddit and join the PICL subreddit thread, you will be able to see that. So that's where I had advertised it this last time. JS, do regular doctors do TNF-alpha testing? What are the other tests you mentioned? So the other test I mentioned was high sensitivity CRP. TNF-alpha or other types of markers for systemic inflammation usually aren't done unless you're getting a highly sophisticated rheumatoid arthritis or other sort of systemic arthritis workup. Obviously, those are tests that can be ordered by your doctor at request, assuming your doctor's on board, meaning Quest and all the big companies will do them. They're not cheap because they're not done that often. Is it possible to have disc bulges that don't present as pain, but the feeling of a weak neck? Yeah, usually possible, but so it's certainly possible to get a weak neck, usually due to irritated nerve or dura that can be caused by a disc bulge. And you may or may not have a lot of neck pain with that. Having said that, there's lots of other things that can cause a weak neck, but that could be one of them. Edgar, what causes chest angina, sharp stabbing pain in dealing with CCI or disc herniation in the cervical spine or thoracic? We made a video of this topic. Thanks for all your videos, by the way. Thank you, Edgar, for bringing that up. So the first thing, obviously, you have to rule out cardiac causes, right? Because that's a big one. And assuming all of that's ruled out by a qualified cardiologist, then CCI or disc herniation, well, let's start with CCI, can cause issues in the thoracic spine and ribs. But many times those are also just areas that independently have issues. So you've got to sort that out. Is the thoracic stuff being caused by the neck, or does the thoracic stuff have a life of its own? That would be a thoracic MRI, a hands-on thoracic physical exam. As far as disc bulges in the neck or herniations causing thoracic pain, you saw the nerve patterns there. Outside of that, usually you're going to look in the thoracic spine for those things. Julie, asking for a friend, can PRP or stem cells help with the complication of difficulty swallowing as a side effect of a fusion? Yeah, it's a good question. Maybe it's not one we've treated a lot. A lot of it would depend on why the difficulty in swallowing is there. Oftentimes it's due to the anterior ACDF plate, in which case probably not going to make a difference. If it's due to some sort of nerve damage or irritation from the fusion, then maybe you could treat it that way. JS, I also have pain that goes to my ear and I feel pressure in my ear and that lowers hearing. Are these nerves in the neck affecting my symptoms? JS, if you go to my YouTube channel, you can see that there's a whole thing on the different nerves and different symptoms. So if you go to the ear symptom short, YouTube short, then it'll talk about the nerves that can cause that. And if you also just look at those 7 nerves in the neck that make CCI patients miserable and go through that, you'll see some of those can affect the ear, and I go through why. Do EDS patients get a switch in types of CCI? For example, untreated C2-3 anterior translation eventually leads to C2 instability 5-10 years down the road. Haven't seen that. More likely would be that maybe 1-2 instability gets finally picked up when a test is done that can show 1-2 instability. That's certainly possible. Snowmass, why aren't there more upper cervical informed doctors? Radiologists detect problems earlier. Why are some doctors don't believe in CCI? Generally curious from a medical professional's point of view. Yeah, I think look at my interview of Fraser Henderson because we got this similar question when we were both online, and I think we both both rolled our eyes and chuckled a little bit. What I mean by that is that he experiences like I do. Both being experts in the upper cervical spine, that there's just a lot of docs that it's outside of their comfort zone. They don't see it all day. They haven't been trained in it. And as a result, they just won't comment a lot on it or look in that direction. I'll give you a great example. Even amongst reading radiologists who should know this, if I held a gun to a doctor's head and say, on this image, find the alar ligament for me, or find the transverse occipital ligament, or find the dentate ligament. We'd have a good number of reading radiologists that would have to look it up before they could find it accurately. When it comes to spine surgeons, we'd have 99 out of 100 who wouldn't be able to find it. When it comes to neurologists, we'd have 999 out of 1,000 who couldn't find it. So these are things they may have been taught once or twice, but they just don't see them all day, every day. I know your stance on Sumasu capsule being useless. I think it's useless because we could have a study of previous sacrifice and those did not cause instability. Read a recent study on isolated 01 capsule sacrificing I don't think I got all of that to answer, but listen, I think we have to be careful with sacrifice studies, right? Sacrifice studies mean that we denuded the whole spine of all the other things that provide stability, and then we started cutting stuff, and then we looked at what that did. So they're not all that accurate in trying to figure out what's causing what. When it comes to the C1, C2 facet capsule, because it has to allow huge amounts of motion, meaning half of all your rotation occurs there, the capsule has to be very, very loose. So it's not going to have a big functional effect. In addition to that, with the 0-1 facet capsule, since it provides all of your head nodding, yes, like that, it also has to be loose. So it's not going to provide a lot of intrinsic stability. Now, if you denude everything, meaning you take off all the muscles, you take off all the fascia, and take everything else out, and you're just at a cadaver and you then cut it, my guess is you will see some increased nodding motion. But is it the primary day-to-day stabilizer of the nodding motion? It's really not. So, and I'm sure there's another one down here for 2 of 2, but I don't see that one yet. It's normal to have trigeminous neuralgia with CCI-AAI or trigeminal neuralgia, ELIN. Trigeminal neuralgia certainly can happen with CCI and AAI. We see that quite a bit. Here's the 2 of 2 causing, I got it. I think I answered that one. Samira, is it possible to have CCI with quite normal imaging? False negative, if yes, what are the options in that case? Yes, Samira, it depends on the imaging, right? If all you had was a routine MRI, then that's not going to find CCI in all likelihood. If what you added to that was a rotational CT, again, unlikely to find CCI if it's present. If what you added to that was a DMX, now we're talking. Maybe, now we're actually getting to the point where we can find CCI pretty routinely. And then if you add an upright MRI to that, and you said all of that's normal, then we're going to start to say, yeah, this person probably doesn't have CCI. But if they just have a routine MRI, I have no idea if you have CCI or not. Or if you add a rotational CT to that, I have no idea if you've got CCI or not. Likelihood of finding it, or meaning having not doing the right test to find it, is high. My daughter has her PI cell number 1 in June, or maybe could be. Yes, had. She's 2 weeks out. Her headache, which was unbearable, was the first thing to subside. Great. She has autonomic issues still. When do nerve irritations tend to get better? I know nerve symptoms are all over the place and hard to categorize or predict. Yeah, Cynthia, we generally don't look at outcome for things like that until the patient gets at least to 3 months. So super duper early here, but I'm glad to hear the headache subsided. And then realize that for most patients, unless we get them very, very early, we're talking about 2 to 4 of these procedures being needed in order to get where the patient needs to go. So those autonomic symptoms may or may not go away after the first one. So just keep all of that in mind. But usually we don't even look till 3 months. Lindsay, I get dizzy when the barometric pressure climbs. Is it related to CCI? I think you're saying you have type 1A, 2A, 2B, 3B, pannus, posterior dens, prosthesis. I think, Lindsay, what you're describing probably with changes in barometric pressure is that as we see changes in barometric pressure, the facet joints can act as little pressure sensors, right? So when the pressure outside here changes, those things are like enclosed little sensors, and they can swell or contract based on the outside pressure. So that's usually facet-mediated issues. So I would imagine that the dizziness is usually from the facets that usually cause dizziness. So things to consider would be the 2-3 facet, or the 1-2 facet would be the most likely facet joints at play. given what you're discussing. Now, could be other things as well, but if we're talking about the upper neck, that's usually what it would be. Caleb, no mechanism of how suboccipital tendon PRP shots got rid of my heavy, or maybe do I know the mechanism of how suboccipital tendon PRP shots got rid of my heavy head feeling? Feels like the posterior muscles. My posterior muscles feel harder, 6 months and counting. Also never had any other symptoms, oddly. Yeah, so I can't tell you your exact mechanism, but what I can tell you is that if you have suboccipital tendinopathy, where these muscles shut down to protect those tendons, meaning the tendons are beat up and the muscles, the suboccipital muscles shut down, you're going to get that bobblehead or heavy head feeling. Once you fix the tendons, your body is going to allow those muscles to come back online, because it now knows that by activating the muscle, it's not going to further damage the tendon. So that's the likely mechanism in that kind of clinical scenario. Hannah, can cervical instability cause jaw and teeth pain on one side of the jaw? It can. So that could be everything from TMJ to different types of trigeminal neuralgia, for example, V2 or V3. Cynthia, Hannah, Conic. Still kid, my daughter gets that. Gotcha. You mentioned many reasons could cause weak neck feeling, excluding CCI, to fractures in the neck, to areas of instability in the neck, outside of CCI, lots and lots of different things. Sam, thanks for the great content. I have massive pain in the upper traps towards shoulders and a little burning in my neck, also some crunching. I have a small disc bulge at C5 through 7 and loss of lordosis. Yeah, so Sam, your treatment could involve those disc bulges, because those could be causing some of what you described based on what we discussed today. But again, that's got to be sorted through, right? Through the same progression that I discussed. It starts with a history where you listen to the patient, and then you look at the actual imaging, and then you do a hands-on exam, and all of that gets synthesized to say, at the end of the day, I think X is causing these upper trap issues. So definitely find someone to follow that path with you. Thanks for taking questions. So helpful. Happy to do it. Is there advantage of upright MRI versus flexion extension MRI of the spine? An upright MRI in our world always includes a flexion extension view. So I would not get an upright MRI unless someone was also doing a flexion extension view, because that's the real value of upright imaging. So I wouldn't do one without the other for sure. John, I work in an equipment room for an NFL team. Why are there almost no PM? I don't know what you mean there, John. I don't get the PM part. Solomon, hi, Dr. Centeno, does normal CXA, BI, BDI measurements mean no CCI? No, those are just some measurements of different kinds of CCI, but there are obviously other types of CCI. So for example, someone could have a normal CXA, BAI, and BDI, but an abnormal C1, C2 overhang and have type 2B CCI. So for instance, a normal CXA would have to be tested both upright and in flexion, but assuming those are normal, then you'd be looking at no type 1A, but you could have any of the other 7 types. Same thing with BAI, right? As an example, if you had a normal, let's say a 2 millimeter translational BAI from flexion to extension, you may have an abnormal C2-3 translation in extension, giving us a type 3B CCI. John, any reason why NFL teams despise PM&R doctors? Looked on the NFL team doctor's website, and each NFL was one primary sports medicine doctor, orthopedic surgeons. Very few teams carry a PM&R doc. Yeah, that's to their detriment. Listen, the orthopedic surgeons that I know that are good surgeons refer out to us all the time. In fact, I've seen, I don't know, a dozen, our clinic's probably seen 3 or 4 dozen NFL players. If you come to our clinic, just look on the walls, you'll see dozens of NFL players up there who have signed little pictures for us. So we see them all the time. The interesting thing is they're not really any different than anybody else, right? At the end of the day, they don't usually need surgery. I think oftentimes they get surgery, but that's even changing, right? Because we now, for the last 10 years, have had lots of NFL sports surgeons or just the players themselves refer themselves for non-surgical care. So I think that's changing with time because what they do is a commodity. And by being a commodity, there's always someone as good or close to as good who's next up in line. So if they can't get back to playing as quickly as possible, then that's a problem, big, huge financial problem for them. Solomon, hi, Dr. Centeno, does a normal CXA, BAI, and BAI measurements? I think I got that one already. Snowmass, would you recommend treatment of disc bulges at lower levels before CCI treatment or after? Usually concurrently with CCI being able to cause a wide variety of symptoms. You ever had consultations with EDS patients where you can't find any objective evidence of CCI, or perhaps they confuse CCI with CCS? Yeah, quite a bit. We've seen EDS patients who don't have CCI or they have CCS, vice versa. EDS patients are a unique population in that they tend to be generally hypermobile. So, the big thing that we've got to do with EDS patients is try to make sure that their symptoms are actually being caused by the upper cervical spine. And there's a whole routine we go through to be able to do that. How do you distinguish locally produced versus referred pains? Good old hands-on physical exam. There's no substitute for it at the end of the day. That is, regrettably a lost art, right? You can go to the doctor and sometimes not get an exam at all or get a very cursory exam. But you go to a doctor that knows what they're doing in this area, and there is no substitute for time with hands on the patient. There just isn't. So if you find someone, just like Dr. Soul said, that is not spending the time to look at your images one by one with you, and point out what's wrong rather than just reading the report. And if they're not spending the time with hands-on patient, you got to find another doctor. John, roughly how strong is the alar ligament compared to symptomatic nuchal ligament? Alar and transverse tend to be stronger. Transverse, I think, is stronger than alar. Alar, stronger than nuchal. Common for CCI symptoms to be amplified when someone is sick. Yeah, Stephen, I think that's the COVID effect. It's interesting. It seemed like during COVID, everyone was surprised to learn that when people have a virus or an infection, that they get lots of inflammation. Heck, we've known about that since the Civil War. That's nothing new. Anytime you're sick, your body ramps up the systemic inflammation to try to deal with the infection. That's one of the mechanisms that you have to deal with infection. So that means that problem that you haven't felt in years, or maybe it's always a little low level in your back or in your knee, all of a sudden you start to feel. Or, another example in the COVID context was when you got the vaccine. It caused a brief inflammatory response that first night, and every old injury you ever had hurt. So it's the same concept. Lindsay, can an upright extension MRI be submitted for DMX in order to diagnose CCI? If you mean upright flexion extension MRI, yes, but just realize that if it shows CCI, then great. If it doesn't show CCI, there's more imaging to be done, meaning that it only shows us certain kinds of CCI and we'll miss other kinds of CCI. Snowmass, can measurements from upright MRI change significantly if more symptoms like heavy head and scalp pain gets worse with previous CCI diagnosis needing a new one? Can measurements from upright MRI change significantly in person? Usually we don't see huge changes in upper cervical upright MRI measurements. So that's something we generally don't see. Okay, guys, well, we are an hour and 5 minutes in now, so I'm going to go ahead and wrap this up. I usually only have about an hour to spend here on a Sunday morning. I want to thank everyone for all of the great questions. Again, this is a format where, there are no bad questions. There's only good questions. And we want everyone to try to learn from each other's questions as well as your own questions. So I'll be doing this again next week, same bat time, same bat channel. So basically what that means is I think we're going to settle on 10 a.m. Mountain Daylight Time, which is noon Eastern Daylight Time, or 9 a.m. Pacific Time. And then again, broadcasting on 2 channels, both YouTube and Facebook. So we'll be doing this again next week. Give me a like on your way out if you haven't already, because that's how other people find this content. And you want other patients to find this content because you want to pay it forward to the CCI and neck injury community, right? You want them to be able to find this so that they can get their questions answered as well. So thanks so much for watching. Have a great week, and I will be back next week. Same bat time, same bat channel. Thank you so much.